Hi everyone, welcome to my channel. I'm super excited for you to be here. My name is Mursi and we're going to continue the U-World concept series. And in this video, I'm going to be talking about idiopathic thrombocytopenic purpura. And it's actually really commonly tested, so it's really good for you to know it. And I'm actually going to make it so easy to pick up. I had so much trouble with figuring out ITP, TTP, HUS, and trying to differentiate from other autoimmune. And I'm reading through it and I'm like, what the heck? What? This is so easy. The vignette it gives it away. So if you're ready to get all the questions right for ITP, keep on watching. I really hope that you do enjoy it. And as always, in this series, it's all concepts from U-World. So you're probably gonna bump into the question, you'll get the explanation, you'll be like, oh, this is what she was talking about. So yeah, let's get started. It's going to be about a child that usually comes in. ITP is commonly seen in children, but it can occur in anyone. You can see some questions maybe in a woman between 20 to 40 years of age. That's commonly, not commonly, but that can be seen. So it's not just children, but it's more common in children and usually about between the ages of 2 to 6. So it'll have, the vignette will have a child coming in, the mom is complaining about how their kid is constantly bruising, easily bruising, or they have purpura or ecchymosis in an area of the body, a couple areas of the body, and so that's what they're coming in for. Or even epistaxis, which is bleeding from the nose. And they'll have in the history something about a viral infection, and that is a huge clue. Do not miss that. If it tells you that they had a viral infection or they just got over being sick about a week to 3 weeks ago, they'll also state lab reports, or they might ask you about the lab reports, what would you see in this patient in their lab reports, and you have to know that it's going to be isolated thrombocytopenia. So obviously thrombocytopenia means low platelet levels. So now why is that? So again, just a quick review. This is so important, so that's why I'm gonna try to repeat, and I tend to repeat myself a lot.
The vignette is gonna have a child with easy bruising, or they have petechia, ecchymosis, they'll have epistaxis. So these are the findings, and then they'll state that that the patient had a viral infection just recently that they got over, so a week to 3 weeks ago. Plus they'll have a lab report with just isolated thrombocytopenia, so you won't have any involvement with the white blood cells, with the red blood cells. It will just be with the platelets.
And the reason why they just have isolated thrombocytopenia is because there's antibody, because remember they had a viral infection, so they don't know exactly the specifics of it, but essentially you have an antibody forming against the platelets. So what happens is you have IgG antibodies that bind to the GP2B3A portion of the platelets, and this antibody then, usually if the platelets all around your body, it doesn't really do anything. It's when it goes to the spleen, that's when the spleen is something looks wrong here, and it's gonna destroy the platelets because it has antibodies against it. And that's what essentially the spleen does. It gets rid of any abnormal cells, including the platelets. So that's why if the spleen is destroying just platelets that has these antibody on it, you're going to only see low platelet counts, and you're not going to see anything to do with the red blood cells, the white blood cells. Nothing else is affected, just the platelets. You might somehow mix up microangiopathic hemolytic anemia, thinking, TTP has schistocytes, which is the microangiopathic hemolytic anemia. HUS has it, and then you're gonna be like, I think ITP has it as well. So HUS, TTP, I think ITP, no, ITP does not have it. You have to remember the mechanism. That's why it's so important to understand the mechanism behind the diseases, because then you can easily exclude things out. ITP has an antibody against the platelets. The platelets are being destroyed by the spleen. You don't have building up of the platelets within the vessels, because essentially microangiopathic hemolytic anemia, I'm kind of like going off topic, but with that you have schistocytes. Why? Because these platelets are in the vessel. So let's say this is the vessels. The platelets are binding to the vessel, and it's kind of forming, it's building, it's forming a thrombosis essentially. So that thrombosis building up, the red blood cells coming through, and it's going to get sheared by that thrombotic, that platelet formed thrombosis, and essentially forming your Helmuth cells, or like the fragmented red blood cells, or the schistocytes, right? But that's seen in more your DIC, TTP, and HUS. It's not seen in ITP. Why? Because there's no thrombosis formation. The platelets are just being destroyed in the spleen. Essentially, that's it. So that's why you're not going to see schistocytes. So if in the vignette it says anything about schistocytes, you have to cross out ITP. But if it doesn't say it, and then it asks you, what could you find in the laboratory finding, or what could you find in the blood smear, you're not going to say schistocyte. But instead, you'll see megakaryocytes in the peripheral blood smear. So that's a finding that you'll see in ITP. Because remember, the platelets are being destroyed, so essentially the bone marrow is trying to make up for the platelets, and then therefore you have these megakaryocytes in the bloodstream. So that's the finding. You will not see splenomegaly. So we said that the platelets are being destroyed in the spleen, but that doesn't mean you're going to have splenomegaly. Now, coming to treatment, how do you treat these patients? This is a question for sure, because there is a difference on how you treat these patients. So if a child comes in and they just have these findings that are on the skin, you know, the easy bruising, the bruises, the ecchymoses, the purpura, then you're just going to observe the patient. That's what you're going to say. You're going to observe. You're not going to treat. The mom comes in, they're like, what do I do with my kid? You're going to say nothing, because they will spontaneously recover. They don't need anything. However, if there is bleeding, if there's bleeding, do treat. You are going to treat. So if they have epistaxis, if they have gum bleeding, if they have any type of bleeding, mucosal bleeding, you're going to treat these patients. What would you treat it with? Corticosteroids or IVIG. So IVIG, remember, it's going to bind to that antibody if you provide them with IVIG, and that antibody is the problem. So that's why you can treat it with that or corticosteroids. If it's an adult, you're going to treat if they have platelet count that's less than 30,000, because they won't get better on their own. They need the corticosteroids, they need that IVIG. You'll give them one or the other, you won't give them both. So if it's greater than 30,000, you're not going to treat the adult. So that's about it. That is your ITP. You will get it right. I promise you, if you just follow what I said. If you need to rewatch this video, definitely watch it, or go into your, actually, you know what's a good book? This is a good book. I mean, it's a lot of information, but it's a good book. And I really hope that was helpful. Let me know in the comment section below if you have any questions, any comments, any concerns, because I do want to make this like more a discussion-based video if possible. That'd be awesome. But stay tuned for more videos. Thank you so much for watching. Make sure to follow me on my Instagram, Mursi Medical, my Snapchat. I don't really use it as much, but I'm on there. And then Twitter, but I don't really use that either. But I definitely do use my Instagram. So follow me on there, and I'll see you guys in the next one. Bye, guys.